Try this right now. Stand up from the chair or couch you're sitting on without using your hands. No pushing off the armrests, no leaning forward first. Just stand. If you can't, or if it was noticeably harder than it was 2 years ago, here's the thing most people in that situation are never told. Struggling to get out of a chair is not primarily a muscle problem. It's a nerve problem, and the difference between those two things completely changes what actually helps. The standard explanation for weakening legs after 60 is muscle loss. Sarcopenia, the age-related reduction in muscle mass and strength, is real. It does happen, and exercise is genuinely the right response to it. Most seniors who mention weak legs to a doctor get told to stay active, build strength, eat more protein. That advice is correct for sarcopenia. The problem is that sarcopenia is not the only thing that makes legs weak after 60. It may not even be the most common thing in people whose legs are noticeably weaker than they were 2 or 3 years ago, despite staying reasonably active. And for a significant proportion of people, it's not even the main thing. When the nerve supply to the leg muscles is being compressed or damaged, those muscles get weaker, regardless of how much they're used, because the signal telling them to contract isn't arriving properly. Exercise doesn't fix that. Targeting the nerve problem does. The reason this gets missed is that from the outside, nerve-related leg weakness looks almost identical to muscle loss. Both produce difficulty getting up from chairs, trouble on stairs, legs that give way without warning, a general sense that the lower body has less power than it used to. The difference is on the inside, in whether the muscle itself is the issue or whether it's the cable connecting the signal to the muscle. Here's the simplest way to understand it. Your leg muscles are like motors: powerful, capable, able to do the job. But every motor needs a cable delivering the signal that tells it to run. That cable is the nerve. If the motor is failing, you strengthen it. If the cable is damaged or pinched, strengthening the motor doesn't help. The motor might be completely fine. Nothing is getting through the cable. After 60, there are 2 specific things that commonly damage or compress the nerve cables running to your leg muscles. Both of them are far more common than most people realize. Neither of them shows up on a standard blood test or a typical physical examination. And neither of them responds to the exercise advice that gets handed out for ordinary muscle weakness. Cause 1, your spine is compressing the nerve roots to your legs. The nerves that control your leg muscles don't originate in your legs. They start in your spinal cord, in the lower back, and travel downward through openings in the vertebrae before branching out into the muscles of your thighs, calves, and feet. As you get older, the channel those nerves travel through gradually narrows, a condition called lumbar spinal stenosis. When it narrows enough, the nerve roots get compressed. The specific pattern of weakness this produces is different from ordinary muscle loss in one important way. It's worse when you're standing or walking, and it gets better when you sit down or lean forward. If your legs feel weaker or heavier after walking for a few minutes, but feel stronger or more capable when you sit and lean forward with your elbows on your knees, that's the nerve root decompression pattern. That forward lean opens the space the nerve travels through. Straightening or arching the back closes it. This is the same mechanism described in the tingling feet video, where we covered why feet tingle specifically at night when you're lying flat. Weak legs from stenosis and tingling feet from stenosis are often the same process affecting different nerve fibers in the same compressed area. If both apply to you, they may have the same source. Cause 2, blood sugar damage to the motor nerves. The second cause is less well known, even among people who know about the tingling and numbness side of diabetic nerve damage. When blood sugar runs chronically high, the nerves affected are not just the sensory fibers that carry feeling. The motor fibers, the ones carrying the signal that actually tells the muscle to contract, are affected too. Motor nerve damage from blood sugar tends to appear in the longest nerves first, which is why it shows up in the legs before the arms and in the lower legs and feet before the thighs. The weakness it produces is gradual, often on both sides, and doesn't have the positional quality of stenosis. It doesn't get better when you sit down. It's there regardless of position. and it tends to be combined with reduced sensation in the same area, feet that feel slightly less, legs that both feel weaker and feel slightly numb or tingly. If your leg weakness is on both sides equally, without the positional pattern of stenosis, and you have any of the foot symptoms covered in the blood sugar feet video, these two processes may be happening in the same nerve network at the same time. The test to do right now. Here are 3 quick checks that help distinguish nerve-related weakness from ordinary muscle loss. None of them diagnose anything. What they do is give you something specific and observable to describe at a doctor's appointment. First is the chair test you did at the start. If standing from a standard chair height without using your hands is difficult or impossible, note that specifically. Use the words lower limb proximal weakness when you describe it. That language points a clinical examination in the right direction. Second, heel walking. Stand near something you can hold on to if needed and try to walk 10 steps on your heels with your toes lifted off the floor. This tests the tibialis anterior muscle, which is controlled by the L4 nerve root. If it's very difficult or your toes immediately drop back to the floor, that's a specific finding worth reporting. Third, the toe tap test. Sit down. Place one foot flat on the floor and tap your toes off the ground as quickly as you can for 10 repetitions. Then do the same on the other side. If one side is noticeably slower, weaker, or lower off the floor than the other, that asymmetry matters. Nerve-related weakness is often uneven between sides, even when it feels bilateral. Muscle loss from aging tends to be more symmetrical. Write down what you found on all 3. Which side felt different, if either did? Whether the weakness changes with sitting versus standing. Why this matters more than just exercising more. Here's why sorting this out is worth the effort rather than just assuming it's aging and pushing through with exercise. The 2 causes on this list don't just look different on a nerve test. They feel different day to day, respond to different things, and get worse from different triggers. Getting the right answer doesn't require being alarmist about what it might mean. It requires knowing which direction to look. If the cause is lumbar stenosis, the interventions that have evidence behind them include specific postural changes, like the forward lean relief position, physical therapy focused on spinal flexion rather than general strengthening, and for more significant compression, clinical options ranging from steroid injections to surgical decompression. Doing general leg strengthening exercises without addressing the compression can actually worsen stenosis symptoms, because some strengthening exercises extend the lower back, which closes the spinal canal further. If the cause is motor neuropathy from blood sugar, the intervention is addressing the blood sugar itself. The motor nerve damage is not reversible once it's established, but slowing and stopping further progression requires getting blood glucose into a stable range. Exercise that improves insulin sensitivity is helpful here, but it's a different goal with a different mechanism than building muscle mass. In both cases, knowing which thing is happening means the effort you put in actually goes toward fixing the right problem, rather than working hard at something that can't address the underlying cause. What to tell your doctor. 2 things to ask for specifically. If the weakness has the positional quality, worse standing, better leaning forward, ask for an MRI of the lumbar spine and mention the words neurogenic claudication when you describe the pattern. That clinical term tells the examining doctor exactly what pattern you're describing and points toward the right investigation. If the weakness is bilateral, non-positional, and comes with any reduced sensation in the feet or lower legs, ask for a nerve conduction study and EMG, electromyography. These tests measure how well the motor nerve signals are traveling to the leg muscles and how the muscles are responding. They are the specific tests that distinguish nerve-related weakness from muscle-related weakness and give you a clear answer rather than a general reassurance that this is just aging. Neither of these tests requires a specialist referral to ask about. They are both standard investigations that a GP can order, and asking for them by name with a clear description of the pattern you've noticed is significantly more effective than describing weak legs generally. 3 things before tonight is over. Do all 3 tests if you haven't already. Chair without hands, heel walk, toe tap both sides. Write down what happened on each one and which side if either was different. Notice tomorrow whether your leg weakness changes with position. Does it feel different when you've been sitting for 10 minutes versus when you've been standing? Write down the pattern, because that single observation is often the most diagnostic piece of information in the appointment that follows. Put neurogenic claudication or nerve conduction study in your phone now if either test or the positional question matches your experience. That language at an appointment produces a different outcome than describing general weakness. General weakness generates general advice. Specific findings with specific names generate specific investigations. Write in the comments how the chair test went and whether the positional question matched your experience. Don't forget to subscribe for more information.